Dear friends and colleagues, I'm Dr. Yasser RIFAY from Morocco. I'm very happy to present this presentation about a complication of lasik. I have no financial disclosure. So the clinical case is a man of 43 years old. He came to our clinic for refractive surgery for far seeing, and corrected visual acuity was very low. The refraction was high myopia of -6 in both eyes with little astigmatism. The best corrected vision was good. The slit examination and the fundus examination was normal with a normal IOP. In the left eye, there were scars of laser for retinal peripheral inferior hole. Preoperative tomography was normal in both eyes with symmetry between the two eyes in antiomorphism. So we went for film to lasik, a flap of 8.8 millimeters with an optical zone of 6 millimeters and a transitional zone of 0.5 millimeter. It was without any incident. Day 1 until day 5, or the first week, visual acuity was good, 0.8, with a clear flap, clear interface, and a very happy patient. In the day 14, he called our office to tell that he had a blurred vision, so we asked him to come to examine him. And visual acuity was 0.6 in right eye, 0.2 in left eye. The eye was white, no pain. It was a haziness in the interface in both eyes, so I thought about DLK and I gave him a treatment of DLK. It was like a DLK grade 2, so I gave him dexamethasone hourly. But the day after, it was the same. The visual acuity was low. The trouble of interface was the same, and I thought about another diagnosis and took the IOP that was 31 in right eye and over 40 in left eyes. This is the slit lamp examination. There is a little bit of haziness in the center. It was the same in both eyes. We've done tomography that showed the ablation zone. The corneal OCT was very useful. It showed us an accumulation of liquid in the flap, between the flap and the stromal bed in the interface in both eyes. So that gave us the diagnosis of a pressure-induced intramural stromal keratitis, which is not a DLK. How we manage it? We had to stop the steroids and give anti-glaucoma treatment, timolol and dorzolamide. 2 days after, normalization of IOP, increase of visual acuity in both eyes, clear interface and flap, and normalization of anterior OCT. And the follow-up, after we give him only one anti-glaucomatous after the 2 weeks, then we stop all the treatment after 3 months, and until 6 months follow-up, the visual acuity was good and the pressure intraocular pressure was normal. So what is PISK? PISK is the differential diagnosis from DLK. DLK starts from the first 5 days, but a PISK is normally after 1 week, and it is not inflammatory. It is an accumulation of liquid in the interface due to hyperpressure in intraocular pressure because of steroids. So in the slit lamp we see clear fluid that fill the space between the flap and stromal bed, and we can see it better with OCT. There is normally no pain. In our case, there is no pain. sometimes we have some PISK that resolve spontaneously. That's why it gives early transient visual acuity loss after LASIK in some case, and even we doctors, we cannot diagnose it because it is transient. And it resolves when the pressure is controlled and it does not respond to steroids, but steroids will complicate the situation. The confocal microscopy examination didn't show any mononuclear cell or granulocytes. It means it's not inflammatory. So the PISK can be reported after some years after surgery, after 5, 6, 7 years. For example, when a patient with LASIK had retinal buckling, had retinal surgery, buckling for the retinal detachment. And OCT is a very good tool to help us to differentiate between PISK, which is a fluid accumulation due to hyperpressure in the eye, and DLK, which is an inflammation in the interface, and the treatment is different. So a DLK-like picture, like we had in our case, appearing more than a week after LASIK may be a PISK. So we have to think about PISK after 1 week. A PISK can explain corneal haze even after years. It is important to measure IUP, and the PISK does not respond to increase of steroids like the LK, but the management consists on lowering the pressure by anti-glaucomatous treatment. Thank you for your attention, and I hope that all the world will be better in few weeks, and we can meet in conferences, and I will invite you all in Rabat, inshallah. Thank you very much.